Every day, healthcare professionals provide care in hospital or at home to acutely or chronically ill patients with disease-related malnutrition. Malnutrition can affect patients of any age and lead to serious clinical complications, far-reaching physical and psychosocial consequences, including poorer quality of life. It is estimated that 33 million European adults are at risk of malnutrition, yet less than half are diagnosed and receive adequate and timely clinical nutrition interventions. With substantial economic burden, disease-related malnutrition costs €170 billion each year to the European healthcare systems. The growing body of evidence indicate that malnourished patients, if treated early with optimal nutrition therapies, have less complications, infections, improved recovery, physical function and independence, and help to optimize the use of healthcare resources. When medical conditions prevent patients from maintaining an adequate nutritional status, Baxter provides life-saving clinical nutrition options to help them regain their health. Our mission to save and sustain lives is at the heart of everything we do to support patients at every step of their journey. With heritage in clinical nutrition since the 1940s, Baxter has been assisting clinicians in treating patients' diverse nutritional needs. Through our passion and expertise, we partner with healthcare providers in all settings, from hospital to home care, to bring innovative solutions to our patients and address their evolving needs at every stage of their lives. For our patients and caregivers who trust and rely on us, we ensure that our transformative and innovative solutions help to advance our mission to save and sustain lives.
What comes to mind when you think of a patient's journey with cancer? Appointments? Scans? Surgery? Chemotherapy? Radiotherapy? Hair loss? Wigs? Bandanas? Remission? Nutrition? Are you aware of the true consequences of malnutrition for your cancer patients? Did you know that malnutrition can lead to increased toxicity and a reduced tolerance for anti-cancer treatments, compromising your ability to effectively treat your patients? Did you know that for your patients, malnutrition can lead to in-muscle loss, less independence, reduced quality of life, and longer hospital stays? Furthermore, malnutrition increases the likelihood of complications, the risk of infection, comorbidity, and mortality. Weight loss is often one of the first symptoms for cancer patients, and feeding problems, issues with appetite, sickness, and nausea are common along the cancer patient journey. Malnutrition is also more prevalent in some cancers, affecting 40% of patients with lung cancer, over 45% of patients with head and neck cancers, almost 50% of patients with gastrointestinal cancers, and up to 70% of pancreatic cancers. Research from France showed that malnourished cancer patients stayed in hospital on average 6 days longer than others. A Dutch study showed that cancer patients receiving nutritional interventions survived almost 6 months longer than patients who did not. A study of Spanish cancer patients highlighted that poor nutritional status was associated with an increased risk of mortality, regardless of patient's age or the stage of their disease. In fact, up to 23% of cancer patients, an estimated 300,000 people, may die due to consequences of malnutrition rather than cancer itself. with the cost of failing to treat malnutrition in the EU estimated at 17 billion euros per year, of which cancer represents a significant proportion. Now is the time to make clinical nutrition a priority. Many patients are not receiving nutrition screening or therapy until it's too late. Why not get time on your side and on that of your patient? Timely nutrition interventions improve clinical outcomes, boosting a patient's energy intake and balance, increasing body fat, giving greater capacity for exercise, and improving quality of life. Nutritional intake with oral or enteral nutrition is often insufficient to meet the nutrition goals of malnourished patients with cancer. This is where early intervention with parenteral nutrition might help you ensure your patients meet all of their nutritional goals and ensure no time is lost. Effectively supporting patients on every step of their cancer journey is crucial to improving clinical outcomes. At Baxter, we remain committed to the cancer community and the important role of timely and effective clinical nutrition along the cancer treatment journey. Contact us to find out more about effective clinical nutrition in cancer patients.
Every day, healthcare professionals provide care in hospital or at home to acutely or chronically ill patients with disease-related malnutrition. Malnutrition can affect patients of any age and lead to serious clinical complications, far-reaching physical and psychosocial consequences, including poorer quality of life. It is estimated that 33 million European adults are at risk of malnutrition, yet less than half are diagnosed and receive adequate and timely clinical nutrition interventions. With substantial economic burden, disease-related malnutrition costs 170 billion euros each year to the European healthcare systems. The growing body of evidence indicate that malnourished patients, if treated early with optimal nutrition therapies, have less complications, infections, improved recovery, physical function and independence, and help to optimize the use of healthcare resources. When medical conditions prevent patients from maintaining an adequate nutritional status, Baxter provides life-saving clinical nutrition options to help them regain their health. Our mission to save and sustain lives is at the heart of everything we do to support patients at every step of their journey. With heritage in clinical nutrition since the 1940s, Baxter has been assisting clinicians in treating patients' diverse nutritional needs. Through our passion and expertise, we partner with healthcare providers in all settings, from hospital to home care, to bring innovative solutions to our patients and address their evolving needs at every stage of their lives. For our patients and caregivers who trust and rely on us, we ensure that our transformative and innovative solutions help to advance our mission to save and sustain lives.
Hello everyone, welcome to our live clinical nutrition webinar. This is Dr. Anıl Höbek. I'm the medical manager for nutritional products in Baxter for Middle East and Africa. And it's our pleasure to welcome you, all of you, in this live webinar session. And in this session, we will be having a very distinctive speaker with us in the second or in the 20th minute of this webinar, Professor Dr. Osman Abbasoğlu. I will introduce him in more details just before his presentation. But as you see on the screen, The webinar will start with a short presentation by me, and then followed by Professor Osman Abbasoğlu's presentation. And then we will have the questions and try to answer your questions after the presentations. Please feel free to send your questions throughout the webinar whenever you wish with the questions and answers function of the platform. And I think that this will be a very interesting topic for your clinical practice. We will be talking about clinical nutrition, starting with some concepts about malnutrition, of course. And we think that the information that will be shared by especially Professor Abbasoğlu will be very much helpful and relevant for your clinical practice, for your daily clinical practice as well. So without further ado, I would like to start my presentation. And as you very well know, malnutrition is a very significant problem, and several studies around the globe has shown us that the prevalence of malnutrition in the hospitals actually is much higher than many people might think about it. So as a general information, or based on those clinical trials that has been conducted, we can say that around 40 to 45% of hospitalized patients are either malnourished or under high risk of malnutrition. And this malnutrition status, as you very well know, ends up with unfavorable clinical outcomes of those patients, like the impairment of wound healing, higher infection rates or other complications, increased hospital and ICU stays, increased healthcare costs, and also increased mortality for those patients. So disease-related malnutrition is a very serious problem with serious consequences, and the treatment should be conducted accordingly. And when we are talking about nutritional treatment, definitely we are talking about the normal nutrition, oral nutrition of the patients. But when it comes to malnutrition in the hospital, assuming that majority of those patients which will require clinical nutritional treatment will not be able to have that opportunity, then enteral or parenteral nutrition will be the choices. I'm not here to describe which patients will need or will have enteral nutrition and which ones will have parenteral nutrition. But the only thing I would like to highlight here is that dotted arrow you see in the middle of the slide, which actually demonstrates the supplemental parenteral nutrition, which is the type of nutritional treatment or type of parenteral nutrition treatment where when applied when the patients receiving enteral nutrition are not receiving the sufficient amount of nutrients and the energy that they need. So supplemental parenteral nutrition to those patients will be a very useful tool for achieving those targets, and Professor Abbasoğlu will talk in details about that. But when we come to parenteral nutrition, as you very well know, there are different options for providing that treatment. One of them being single bottles. Although rarely, there are still some centers which practice such kind of treatment where all the nutrients or the nutritional components are given to the patients separately with separate infusions. This makes the nutritional treatment much more complicated and very much risky, actually. And there are also the mixtures that we can use during our practice. And those mixtures can be prepared by compounding, either manually or by a machine, which we call the automated compounding, or those mixtures may be prepared upfront by the industry and shipped to the clinical centers to be readily available for using for the parenteral nutrition treatment for the patients, which we call them multi-chamber bags. If they include three elements of parenteral nutrition, the three macronutrients, then we call them three-chamber bags or three-in-one solutions. So the either compounded or multi-chamber bag products, the admixtures can be 2-in-1, as you can see here, or 3-in-1. As I said, 3-in-1 contains all the macronutrients, and 2-in-1 contains the amino acids and the carbohydrates, where the lipids are given separately. And the recommendation of the ESPAN Society is to provide parenteral nutrition treatment with all-in-one systems, which means by using 3-in-1 formulations, either compounded or as multi-chamber bag products. While using multi-chamber bag products, you as healthcare professionals may have some questions, concerns in your mind, whether or not this standardized bag will be fitting to all the patients, or such multi-chamber bags will bring some disadvantages or advantages regarding to patient safety. And also there will be some questions related with the cost of that treatment. As I have mentioned, Professor Abbasoğlu will be talking about many of those aspects with regards to parenteral nutrition, and he will give us a comprehensive overview of the compounding practice and also multi-chamber bag practice. But I will try to answer these questions very basically here. If you look at the first question, if one size fits all the patients or not, what we can say is that it may not be fitting all the patients, but it will definitely be suitable for the majority of the patients requiring parenteral nutrition treatment. And this actually has been proven by several studies. And here you see one example comparing the multi-chamber bag products with a compounding parenteral nutrition practice. And in that comparison, the primary outcome was comparing the caloric requirements received by the patients, and 70% achievement with regards to their daily caloric requirements was set as a target. And there was no difference between the multi-chamber bags and the customized bags in terms of achieving the energy target, which was the primary outcome. The secondary outcome was also the same or similar with the compounded bags and multi-chamber bags, and the secondary outcomes was meeting 90% of the daily caloric requirements and 70% of the protein requirements. So we can say that in both from both energy and also the protein perspective, the multi-chamber bags will be able to addressing the requirements of the majority of the patients. And several, as I said, there are several studies which give us such similar outcomes as well. And here is another study which shows that multi-chamber bags are able to provide the required amount of nutritional elements, But in addition, the authors in that study have identified a significant time saving with three-chamber bag product usage. And when we look at the situation in practice, what is actually in practice, we can see that a significant amount of patients in Western Europe, the adult patients especially, are receiving standardized and multi-chamber bag products opposed to individualized, customized, compounded treatment. Yes, in pediatric and neonatal patients, compounding is still the frequent practice, I may say, but even in the pediatric and neonatal patients, the standardized parenteral nutrition practice is gaining popularity, and multi-chamber bags are also having an increased rate of usage every year. And the advantages of those multi-chamber bags in pediatric and neonatal patients are also highlighted in some papers in the literature as well. So it meets the requirements of majority of patients, and when it comes to the safety advantages due to lower number of manipulations to the bag, multi-chamber bags will help minimizing the compounding and prescribing errors, while they will also help minimizing the microbiological contamination of the bags. And this has also shown in several studies in the literature that the rate of bloodstream infection was significantly reduced by multi-chamber bags when compared to the compounded bags, outsourced and compounded bags, and also the in-hospital compounded bags as well. And this difference is also significant in terms of the ICU stays of those patients, where the ICU stays was much lower in the multi-chamber bag patient group compared to the others, and also the hospital length of stay was significantly lower in those patients. And the total treatment costs would also be positively impacted in several situations by multiple chamber bag parenteral nutrition. And another study showing the bloodstream infection reduction with multi-chamber bags compared to the compounding practice. But in the 28 days mortality, there was not such a significant difference between the two modalities of treatment. Lastly, about the costs, of course, the cost of a treatment will depend on the financial dynamics and the prices within a country, and also labor costs, indirect costs within the country, and also within a hospital. So it would be beneficial for every hospital to make some kind of an exercise of cost comparison on their own. But there are several studies in the literature demonstrating the benefits of multi-chamber bags in terms of helping the reduction of direct costs and also the indirect costs in the hospital. And Dr. Abbasoğlu will talk about these aspects of parenteral nutrition as well. So to conclude my presentation, the use of multi-chamber bags, three-chamber bags, is time-saving, safe, and it is supported by the guidelines, because guidelines recommend using all-in-one solutions and preferring standardized nutrition formulations as much as possible, rather than customizing it for each and every patient. And use of compounded parenteral nutrition definitely provides individual nutritional therapy, especially for patients with specific needs. So compounding may be considered for those specific patients. Depending on availability and appropriate usage, three-chamber bag parenteral nutrition is clinically relevant, and three-chamber bag parenteral nutrition products help meeting the needs of the majority of patients. They are easy and convenient to prescribe and use, and they minimize the errors, and they reduce the bloodstream infections. So to conclude with the ESPEN and ASPEN statements in the guidelines, ESPEN states that PN admixtures should be administered as a complete all-in-one bag, and ASPEN endorses the standardized process for parenteral nutrition management by standardizing the formulation and using commercial PN products, and also standardizing the ordering, labeling, screening, and administration of standardized commercially available parenteral nutrition products. With that, I would like to end my presentation here. And as I said, we will be having your questions after the presentation or after the following speech of our invited speaker, Professor Dr. Osman Abbasoğlu. He is a professor of surgery, and he was born in Ankara, and he received a MD degree from the Hacettepe University in 1884. And he conducted his general surgery training in the same university hospital, Hacettepe University Hospital, and he completed a clinical transplantation fellowship at Baylor University Medical Center in Dallas. And he has served and taught as professor of general surgery in Hacettepe University School of Medicine between 2003 and 2020. And he also has led the nutrition support team in the university hospital as the director between 1997 and 2010, and director of clinical nutrition master's degree program role is still continuing. And he has published more than 90 peer-reviewed articles and 12 book chapters, mainly on nutrition and hepatopancreaticobiliary surgery. He serves on multiple committees, and he's a member of multiple specialty societies. He's currently associate editor in Clinical Nutrition Journal, which is the journal of ESPEN Society. He was the representative of Turkey at ESPEN Council between 2014 and 2018, and president of Turkish Enteral and Parenteral Nutrition Society between 2019 and 2021. And he's currently the secretary of Adriatic Club of Clinical Nutrition. So it's my honor and pleasure to invite Professor Osman Abbasoğlu for his presentation to the camera and the microphone. Hello, Professor Osman Abbasoğlu. Welcome.
Thank you very much, Anil. Thank you and good evening. In this 50 minutes, I will talk on general principles of parenteral nutrition with 3 chamber bags, and I will emphasize on the importance of lipids and proteins. Actually, this is a 50 minutes talk. I know it's long, but I'll do my best not to bore you. This is the outline of my talk. First of all, I will talk on the principles of parenteral nutrition and compounded versus 3-chamber bags. Then I will talk on the lipids in parenteral nutrition, proteins in PN, supplemental parenteral nutrition, and finally, I will give some important guidelines and conclude my talk. Let me start with principles of parenteral nutrition. Before getting into the topic, I would like to ask you a poll question, and I would like to ask you to vote. Which route for nutrition therapy is more safe? A, enteral nutrition, B, parenteral nutrition, C, EN and PN are equally safe. Please vote on your screens now. Okay, I got the answers. No, it's not finished yet. Okay, let's wait for a few more seconds. Okay, the majority says they are equally safe, or it's still changing. Let's wait for a few more seconds. Let's wait. It's like stock market changing continuously. Okay, let's stop voting. About 60% says they are equally safe, and the rest says enteral nutrition is safer. Okay, I will give the answer of this question during my talk. In this 50 minutes, I will not talk about the importance of malnutrition and nutrition assessment methods, but just in one slide, I would like to emphasize the association between malnutrition and hospital mortality. This study is coming from Australia and New Zealand. This study was on more than 3,000 patients in 56 hospitals. The authors found that 32% of their patients were malnourished. Now, please look at the right-hand side of your screen. On the y-axis, you see the 90-day in-hospital mortality rates, and blue lines represent well-nourished patients, and yellow lines represent malnourished patients. In this study, the authors showed that 90-day in-hospital mortality was twice greater for malnourished patients. So it's clear that malnutrition associated with high mortality rates. Is parenteral nutrition safe? I would like to mention Professor Stanley Dadrick. He's an American surgeon, and he published his first article on parenteral nutrition in 1968 in JAMA. Professor Dadrick is the pioneer of parenteral nutrition. His first patient was an infant who was successfully treated with intravenous hyperalimentation. At that time, they were using the term hyperalimentation. And you see myself and Dr. Dadrick in a meeting in Poland a few years ago. At that time, I was younger and my hair was more black. After Dadrick's publications, parenteral nutrition is popularized. But a few years later, there were some concerns about the complications of parenteral nutrition. But later on, in 2001, an article appeared in the American Journal of Clinical Nutrition. And in this article, a Canadian gastroenterologist, Jejeboy, stated that dangers of TPN-induced complications have been exaggerated. Now I will focus on some main indications of parenteral nutrition. I think the main indication is intestinal dysmotility and mechanical obstruction. Another important indication is intra-abdominal infections and high output GI fistula. In the middle, you see one of my patients with a fecal fistula who was treated nicely with parenteral nutrition. An important indication is short bowel syndrome or intestinal ischemia. Other indications include, but not limited to, extensive small bowel mucosal diseases and severe GI bleeding. What about the requirements for parenteral nutrition? Generally, energy requirement is somewhere between 20 to 30 kilocalories per kilogram per day. For critical patients, for patients in ICU, we usually go with 20. For regular ward patients, we use 30 kilocalories per day. Protein requirement is usually 1.2 to 1.5 gram per kilogram per day, and there is an increased demand in severe stress and burns. Besides these macronutrients, micronutrients, namely vitamins and trace elements, and water and electrolytes also should be added to the admixture. I would like to stress the importance of vitamins and trace elements. Why? Because neither hospital compounded nor commercial 3-chamber bags contain vitamins or trace elements. Because of this, trace elements and vitamins should be adding to the nutrition bags according to the hospital regulations. We recommend adding these micronutrients in the central pharmacy to minimize interactions and also to minimize contamination. Basically, there are two ways of delivering parenteral nutrition. First one is central parenteral nutrition. In central parenteral nutrition, the solution is delivered to the central vein. And this is an advantage. This has advantages because you can use hyperosmolar solutions, and there is no energy or protein limitation. For central parenteral nutrition, we suggest to use right subclavian vein or peripherally introduced central catheters. For long-term parenteral nutrition or for home parenteral nutrition, we recommend tunneled catheters or implanted ports. What about peripheral parenteral nutrition? It's practical. Why? Because it avoids complications related to central venous catheterization, like pneumothorax, like vascular injuries. But for peripheral parenteral nutrition, we have a certain limitation. We have to keep the osmolarity of the fluid or osmolarity of the solution below 900. If you keep the osmolarity less than 900, it means you may not achieve the nutritional goals. And as a result of this, peripheral parenteral nutrition is good for short-term therapy, usually shorter than 2 weeks. Here, I would like to share my university experience with you. In Hacettepe University, in the last 2 years, we served about 900 patients. And among these 900 patients, about around 600 received parenteral nutrition, and 2/3 of them received peripheral, and about 40% received central parenteral nutrition. As you clearly see, we use peripheral parenteral nutrition liberally because it's practical and it avoids complications of central catheterization. My poll question was, which one is more safe, enteral nutrition or parenteral nutrition? I think the answer of this question is in the study. This is an important study published in a New England Journal of Medicine in 2014, and the study was reported by Schiller Harvey and Associates. It's a randomized study in the critically ill patients. It's a pragmatic study. The patients are grouped into two. The first group received parenteral nutrition, and the other group received enteral nutrition, regardless of their GI function. It's a pragmatic study, just comparing PN to EN. And this is the findings of the study. The primary outcome of this randomized trial was 30 days mortality rate. And as you can see in the parenteral group, 30 days mortality rate was 33%, and in the enteral group, it was 34%. So basically same. Secondary outcome of this study was infectious complications, length of hospital stay, and length of ICU stay. And similar to that of mortality, no significant differences were seen in the number of treated infectious complications. This is an amazing study, and the authors conclude that enteral nutrition and parenteral nutrition are equally effective and equally safe. So the answer of my poll question was both of them are equally safe. What about the complications of PN in the elderly? I know many physicians are not very keen on giving parenteral nutrition to the elderly people, elderly patients, because they are scared of possible complications, but this is our own data. Please look at line 2, the comorbidities of the patients. The comorbidities of these patients are high in the elderly patients, including diabetes, renal failure, chronic obstructive pulmonary disease. But when you concentrate on the complications rate at the lower part of your screen, complication rate in the young group was 14%, and in the elderly patients, it's 16%. So this data, I think, clearly shows that parenteral nutrition is also safe in the old patients. And fortunately, many complications of parenteral nutrition can be prevented. During catheter insertion, complications like hemothorax or pneumothorax or other vascular injuries may be seen. We suggest to use sonography guidance. With sonography guidance, complications during vascular access are significantly decreased. Another important complication is metabolic complications. To avoid metabolic complications, we suggest avoiding overfeeding, because overfeeding increases infections and mortality rates. And finally, close monitoring of the patients is crucial to decrease complications. The catheter-associated bloodstream infections are among the detrimental complications of parenteral nutrition. Basically, there are 4 potential routes for catheter-associated infections. In this slide, you see these 4 routes of contaminations. The third and fourth one, hematogenous spread and contamination of the IV fluid, are seen very rarely. On the other hand, migration of the skin organisms is the common reason in the first few days, and after day 10, contamination of the catheter or catheter hub is the leading cause of infections. And because of this, full barrier precautions and all safety measures should be applied to decrease catheter-associated bloodstream infections. And today, 0 bloodstream infection rate with parenteral nutrition is achievable. I said that overfeeding may cause infectious complications. This is a nice observational study showing the relation between overfeeding and infection. The gray bars shows the patients without infection, and orange bars shows the patients with bloodstream infections. On the x-axis, you see the maximum parenteral energy. As the maximum parenteral energy increases, the risk of infection is increased. So what we can conclude from the study is blood sugar regulation decreases infectious complications in the critically ill patients during parenteral nutrition. One of the most important strategies to decrease the rate of bloodstream infections in parenteral nutrition is exit site selection. Here you see 2 wrong exit site selection. We don't want to use neck veins, internal jugular veins. Indeed, it's critically important to move from neck to chest. If you use subclavian approach, infectious complications are significantly decreased. Why? Because we secure the catheter firmly. There is no in and out movement of the catheter, and also the quality of life with subclavian approach is improved because they have free neck and head movements. Another access route that we recommend is peripherally inserted central venous catheters. This also avoids central catheterization complications. Infectious complications are less, and it's very practical. So you can use either subclavian approach or use PICC catheters for central parenteral nutrition. And also, I would like to stress the importance of nutrition support team to decrease the possible complications of parenteral nutrition. Nutrition support teams consists of physicians, dietitians, nurses, pharmacists, and they work as a team to improve patient quality. And finally, home parenteral nutrition is feasible. These are two pictures from my team. If you educate family members appropriately, home parenteral nutrition is equally safe as in hospital parenteral nutrition. Dear friends, dear colleagues, in the second part of my talk, I will briefly touch compounded versus three-chamber bags because Anna discussed this topic in detail. Let me summarize their differences. In three-chamber bags, you mainly give standard nutritional requirements. But for compounded bags or customized bags, we have more room for specific nutritional requirements. As an example, patients with electrolyte imbalance or patients with fluid restriction may benefit from compounded bags. In my institution, we performed a cost analysis, and we found that if a hospital or an institution serves less than 15 patients, compounding is more expensive. So I suggest small or medium-sized hospitals to use definitely three-chamber bags, but for bigger hospitals, it depends on the local conditions. Now I will move to one of my main topics, lipids in parenteral nutrition. Again, I would like to ask a poll question, and I will ask you to vote. Which fatty acid is immunologically neutral? A, soybean oil, B, fish oil, C, olive oil, D, all of the above. Please vote now. Okay, let's start the voting now. About 60% voted for olive oil and the others voted for the rest. Now it's 56%. Okay, let me move to my presentation. Let me start this section with the definition of lipid. What's a lipid? Lipids are an important source of energy. And in clinical parenteral nutrition, lipids are used as triglycerides. A triglyceride consists of three fatty acid molecules bonded to a glycerol molecule. There are many different classifications of fatty acids, but the most common classification is regarding to their degree of saturation. And regarding to the degree of saturation, fatty acids can be classified into three. Saturated fatty acids, they have no double bonds. Monounsaturated fatty acids, they have single double bond, as an example, olive oil or oleic acid. And polyunsaturated fatty acids have more than one double bond, as an example, linoleic acid. I would like to stress the importance of essential fatty acids. What's essential fatty acids? Essential fatty acid means fatty acids that cannot be synthesized in the body and must therefore come from our diet. So we have to take essential fatty acids by our diet because we cannot manufacture them. Basically, we have two essential fatty acids, linoleic acid and alpha linoleic acid. Are all lipid emulsions same? In clinical parenteral nutrition, we basically use 4 lipid emulsions: soybean oil, MCTs, olive oil, and fish oil. Although all these lipids yield same amount of energy, they have different effects on mainly inflammation, immunity, and lipid peroxidation, and also they have different effects on patient outcome. If you place these lipid solutions in a scale, soybean oil is the pro-inflammatory lipid, and fish oil is anti-inflammatory lipid. So soybean oil is on the one side and fish oil is on the other side. And MCTs and olive oil just lies between these two. Oxidative stress is an important phenomenon in our body. Oxidative stress occurs when there is an imbalance between reactive oxygen species production and antioxidant systems. Actually, free oxygen radicals are generated in our body continuously as a result of our metabolism. When a normal oxygen atom loses an electron, it becomes free radical. And thanks God, these free radicals are neutralized by antioxidant systems. If these antioxidant systems are not good enough to neutralize this oxidative stress, the generation of free radicals results in damage to lipids, proteins, and most importantly, to DNA. Basically, oxidative stress is detrimental for our organism. Fortunately, oleic acid has single double bond. It's monounsaturated fatty acid. And single double bond makes olive oil less prone to lipid peroxidation. So it has a protective role against oxidative stress. And in addition to that, metabolism of olive oil does not produce eicosanoids, and this renders olive oil to be inflammatory neutral. So the answer of my poll question is olive oil is inflammatory neutral. The management of patients in ICU has many aspects. These patients may have persistent inflammation, they have poor wound healing, and they are prone to infection. Association between critical illness and ICU acquired weakness deserve attention. Nutritional treatment for the treatment of malnutrition and physical rehabilitation for the treatment of inactivity are essential factors for the prevention of ICU-acquired weakness. And lipids are a good and concentrated source of energy in the critically ill. Now, I would like to move to pathophysiology, to the response to trauma or illness. I love these slides because it gives the clear picture of immune modulation. Now, let's imagine a patient who has a trauma. This trauma can be a traffic accident, acute pancreatitis, or surgery. In response to trauma, the usual response is systemic inflammatory response syndrome, or SIRS response. It's beneficial and it is needed to fight against the trauma. In 3 or 4 days, SIRS response makes a peak and then it slows down and reaches a plateau. If SIRS response is exaggerated, it may result in early multi-system organ failure and with fulminant death. In other words, although SIRS is essential and critical to fight against injury, if it is exaggerated, it may have detrimental effects and may result in fulminant death of the patient. In our organism, if a system is operating on one way, there is a compensatory system just operating on the opposite way. In response to trauma, this compensatory system is CARS, compensatory anti-inflammatory response syndrome. CARS operates just the opposite way of CARS, and also it's necessary to balance SIRS. But similar to that of SIRS, if CARS is exaggerated, it may result in progressive immunosuppression and with indolent death of the patient. If the patient is lucky, and if we managed and treated the patient well, he or she may have an uncomplicated outcome, which means SIRS and CARS response will merge in the midline and patient will have a rapid recovery. This is uncomplicated outcome. But if the insult was strong and the management was poor, either SIRS or CARS may gain the war and we may lose the patient. What I understand from this pathophysiology is response to trauma or injury is complex. And if we do not know where our patient is in this complex scenario, it may be dangerous to modulate immunity. And this is my conclusion from the pathophysiology. Inflammation is generally a beneficial response to trauma or illness, but immune modulation with lipids or without lipids has the potential to be harmful. Now, I would like to summarize some basic characteristics of lipids. Soybean oil, it's a source of essential fatty acids and it's pro-inflammatory. MCTs, they are less pro-inflammatory. Olive oil, it's immune neutral. And fish oil has anti-inflammatory properties. Now, I would like to present you the largest prospective randomized open-label study comparing fish oil with soybean oil. This paper is coming from China and is performed on more than 450 patients who underwent surgery. Patients are allocated into two groups, olive oil and soybean oil. This is the result of the study. The dark green bars represent olive oil group and light green bars represent soybean oil. In the study, authors concluded that with olive oil, infectious complications and number of patients who are infected are decreased significantly with olive oil-based parenteral regimens. On the other hand, in the study, there were no differences in the length of stay and mortality rates. What about fish oil? I don't want to bore you with many studies, but just I would like to share a recent meta-analysis with fish oil in ICU patients. This is a meta-analysis including 24 randomized controlled trials and more than 1,400 patients. And in this meta-analysis, authors found that with fish oil, risk of infection, hospital length of stay, and ICU length of stay were decreased in fish oil group compared to standard parenteral nutrition. When we look in detail to this study, on the top you see the infection rates. The diamond is favoring fish oil. What about ICU length of stay? You see the diagram on the bottom. Again, the results are favoring usage of fish oil. So according to this meta-analysis, fish oil may be helpful in the critically ill. But I think one should be very skeptical about evaluating lipid studies in the literature. As an example, a few years ago, a group of physicians, we gathered and wrote a critical paper about fish oil containing lipid emulsions in adult parenteral nutrition. And this paper was published in JPEN. We mainly analyzed sepsis, infection, and general outcomes in studies using fish oil. And the results of our review were striking. 76% of the investigated studies, 25 out of total 33 studies, had very low quality evidence. In other words, it's very hard, it's very difficult to rely on these studies. Why? Because most studies were underpowered, they used inappropriate statistical methods and lacked details on study protocols and methodology. So I suggest you to be skeptical while reading lipid studies in the literature. And in accordance with our critical review, ASPEN guidelines, which published just few days ago, stated that they don't recommend only fish oil in the critical patients. In the recommendation of question 5b, ASPEN suggests that either fish oil or non-fish oil containing lipid emulsions can be used in the critically ill patients. And they also stated that the quality of evidence of the trials was generally low in parallel to our fish oil review. Now, dear friends, dear colleagues, I would like to move the second important part of my presentation, proteins in parenteral nutrition. Again, I would like to start with a poll question to this section. Protein requirement during critical illness is usually 0.8, 1, 1.3, or 2.0 gram per kilogram per day. Please vote now. Okay, we can stop the voting now. The majority voted for 2 grams and the rest voted for 1.3 gram per kilogram per day. Okay. The response to injury is typical in human beings, regardless the cause of injury. This may be acute or chronic disease, this may be trauma, surgery, whatever. The typical response is ACTH and cortisol elevation and elevation of cytokines, mainly IL-1 and TNF-alpha. And unfortunately, the net effect to response to injury is protein breakdown. And most fragile patients in clinical practice are cancer patients, patients with advanced age, presence of chronic organ failure, and critically ill patients. In these patients, the common denominator is sarcopenia. What's sarcopenia? Sarcopenia is the progressive decline in skeletal muscle mass leading to decreased strength and functionality. So basically, sarcopenia has 2 components, loss of mass and loss of function. And sarcopenia is associated with increased mortality rates. What about the risk factors for sarcopenia? For acute, rapid wasting disorders like critically ill, the major risk factor is inflammation. On the other hand, in chronic conditions or in age-related sarcopenia, inactivity, anabolic resistance, inflammation, and some other factors may contribute to the development of sarcopenia. Recently, all over the world, we are fighting against COVID-19 disease. And we all know the risk factors for mortality in COVID-19, old age, polymorbidity, and sarcopenia. and all of them are related to protein malnutrition. Protein malnutrition is also a risk factor for high mortality in COVID-19 disease. This is an old study, but a very important study that I would like to share with you. In this slide, in the upper part, you see the resting metabolism, and in the lower part, you see the nitrogen excretion in different clinical conditions, including fracture, peritonitis, or major burn. In response to trauma, the resting energy metabolism is increased, and also similarly, nitrogen excretion, in other words, protein breakdown is also increased. Now, let's focus on major burns. As an example, in major burns, resting metabolism is increased 1.8-fold. On the other hand, nitrogen excretion is increased 3-fold. What I understand from this analysis is protein breakdown surpass energy metabolism increase in the critically ill. What's the clinical application of this study? We have to supply our patients with enough proteins besides energy. Although protein requirements are increased in the critically ill, it's not easy to achieve the goals in ICU patients. This analysis is coming from Hayland Group. This is a multinational and multi-center study showing the correlation between prescribed and achieved proteins. The orange bar represents prescribed, and the blue bars represent supplied protein amounts. As you can clearly see, overall, patients received only 50 to 65% of proteins prescribed. In other words, we are trying to give proteins, but in the daily life, they could not achieve the protein goals for some reasons. This is another study that I would like to share with you, performed by Waits and Associates, Mortality and Energy Deficit Association. In the y-axis, you see the mortality rates, and on the x-axis, you see the energy deficit. The orange bar represents the patients with 10 to 20% less amount of energy estimated. Surprisingly, the lowest mortality is seen in patients who achieve 10 to 20% less energy. On the right-hand side, you see the patients with no energy deficit, and they have a higher mortality rate. On the other hand, in this analysis, the authors also analyzed protein intake. On the y-axis, again, you see the mortality rates, and on the x-axis, you see the protein delivery. The patients who receive more than 1.2 gram proteins per kilogram per day had the lowest lowest mortality. What I understand from this observational study is giving higher amounts of protein, but lower amounts of energy may be beneficial in the critically ill patients. And this is the last study that I would like to share with you, performed by Alan Grapp and Associates. It's also an observational study. On the y-axis, you see the survival rate. The gray line represents patients with low protein, and orange line represents patients with high protein. As clearly seen in this analysis, the highest survival was seen in patients who achieve higher proteins. In this study, high protein was 1.46 gram per kilogram per day. And finally, in the last part of my talk, I will concentrate on supplemental parenteral nutrition And I would like to ask my last poll question. When supplemental parenteral nutrition should be considered? If at least 60%, if at least 75%, or if at least 90% of energy and protein requirements cannot be delivered by enteral route alone. 60, 75, or 90% of the goal is considered in this question. Okay, we can stop the voting. The majority says 60%. Yes, that's the correct answer. I will explain this in my slides. Now I would like to focus on gastrointestinal dysmotility in our patients. Gastrointestinal dysmotility is very common in many patients, in surgery, in the critically ill, in cancer, in geriatrics. Why? There are many reasons, including paralytic ileus, immobility, intra-abdominal infections, pressors, whatever. And in these patients, because of gastrointestinal dysmotility, nutritional goals cannot be achieved in many patients. Despite this, we have to implement enteral nutrition at least for trophic enteral nutrition. Trophic enteral nutrition means feeding the intestines. With trophic intestine, all nutritional requirements cannot be supplied. And on the other hand, pharmacological options to stimulate bowel motility are limited. I have to say that trophic nutrition is very important for immunity and for intestine, but may not be good enough to feed the patient. In this case, I suggest to use supplemental parenteral nutrition. Supplemental parenteral nutrition means if at least 60% of energy and protein requirements cannot be delivered by enteral route in few days, parenteral nutrition should be combined with enteral nutrition. In other words, supplemental parenteral nutrition is combination of EN with PN. I would like to give an example. Imagine a patient who is 70 kilograms, a male patient, and his energy target is 2100 kilocalories per day, but the patient could not tolerate more than 50 milliliters per hour enteral nutrition. In this case, the patient can receive only 1200 kilocalories. In this case, the patient is unable to meet at least 60% of energy requirements, and we have to calculate the energy deficit. The deficit is 2100 minus 1200, and it's 900. So what we have to do is giving this 900 kilocalories by supplemental parenteral nutrition. Nutritional goals can be achieved with supplemental parenteral nutrition. This is my center's own data, and we published our data last year. Please concentrate on the last line of this slide, patients who achieved nutritional goals. With enteral nutrition alone, 63% of the patients could reach the goals. With parenteral nutrition, this is about 60%, but with supplemental parenteral nutrition, about 93% of our patients could achieve nutritional goals. So in summary, supplemental parenteral nutrition is very helpful to achieve nutritional goals. And this was confirmed in a randomized study by Heidegger and Associates, and this paper was published in Lancet. In this study, the authors randomized the patients on in two groups. One group received enteral nutrition alone, and the other group received supplemental parenteral nutrition, enteral and parenteral nutrition combination. And nutritional goals could be achieved in the supplemental parenteral nutrition group, and the infectious complications and mechanical ventilation days were significantly decreased with implementation of supplemental parenteral nutrition in these critically ill patients. Now, dear friends, dear colleagues, I would like to conclude my talk with guidelines and summarize my presentation. As you all very well know, we basically have two important guidelines. The first one is ASPEN guidelines, American Society guidelines, and the other one is ESPEN guidelines. ASPEN, American Society, revised their ICU guidelines just few days ago and published in JPEN in year 2022. To tell you the truth, this guideline does not cover all the aspects of nutrition in the critically ill patients. At the previous guideline, which was published in 2016, was more comprehensive. Now, in the last few minutes, I would not go in detail in these guidelines, but just focus on certain recommendations. In ASPEN guidelines, the recent one, 2022, EN versus PN, this is ASPEN recommendation. There was no significant difference in clinical outcomes between early exclusive PN and EN during the first week of critical illness. So ASPEN clearly recommends that enteral nutrition and parenteral nutrition are equally safe and effective. This is an important achievement in the guidelines. What about lipids? There is not much recommendation in the last or most recent ASPEN guideline, but in the previous ASPEN guideline, ASPEN suggests that immune modulating formulas not be used routinely in patients with severe sepsis. In 2022 guideline, there is no clear recommendation about the lipid solutions. So you can use either of them according to ASPEN guidelines. What about ESPEN guidelines? In the last 3 years, ASPEN revised also the guidelines and published guidelines in cancer, in surgery, and intensive care unit. I would like to draw your attention to certain aspects of these guidelines. Clinical nutrition in the ICU. ESPEN recommends that early and progressive PN can be provided instead of no nutrition in case of contraindications for EN in severely malnourished patients. In other words, if your patient is severely malnourished, you can start PN anytime in ICU. You don't need to wait. This is what ESPEN recommends. What about surgery? Regarding surgical patients, parenteral nutrition shall be administered as soon as possible if nutrition therapy is indicated and there is a contraindication for enteral nutrition. So in surgery, the first choice for ESPEN is enteral nutrition, but if the patient cannot tolerate enteral nutrition, start PN as soon as possible. Do not wait. And in my last slide, I would like to summarize protein requirement recommendations in ESPEN and ASPEN guidelines. Basically, these guidelines are similar. You don't need to memorize all critically ill surgery, cancer, and burns. Basically, if you go with 1.3, which was my poll question, you are giving the correct amounts of proteins. In certain conditions like burns, you can increase proteins up to 2 grams. Except for burns, 2-gram proteins are rarely required. Dear friends, dear colleagues, these are my conclusions and takeaways. If GI is not functional, parenteral nutrition is the treatment of choice for nutritional treatment. During parenteral nutrition, most of the complications can be prevented with close monitoring. There is no significant difference in clinical outcomes between early exclusive PN and enteral nutrition. In other words, they are equally safe. The major difference of lipid solutions is their effect on immune system. In the critically ill patients, soybean-based intravenous lipid emulsions may interfere with immune function and may have deleterious effects. So I suggest not to use soybean oil in the critically ill in the first week. Immunological and inflammatory neutrality and limitation of lipid peroxidation are the major advantages of olive oil-based intravenous lipid emulsions. And finally, patients may benefit from strategy providing more than 1.3 gram proteins per day. And if enteral nutrition alone is not able to provide the necessary nutrients, combination of EN and PN should be considered. I would like to thank you all for spending an hour in this webinar. By these three photographs, the one on the left is from Dubai night. The middle one is a general view from Lebanon, and the right one is Old Town in Cairo. Thank you very much.
Thank you very much, Professor Osman, for this very informative presentation. And we have quite a lot of questions, actually, from our audience. And by the way, you can still continue asking your questions through the chat function. So I will start with this question. How would you determine the requirements of a particular patient? How would you determine the calorie requirement, energy requirement? How would you prescribe?
Yeah, that's a very important question. The golden standard is indirect calorimetry. So I would suggest to use indirect calorimetry. Although there are some limitations of indirect calorimetry, still it's the golden standard. But I know that indirect calorimetry is not available in many hospitals. They are quite expensive, and some clinics think that they may not be practical. In this case, I would suggest to use kilogram formula. If the patient is in ICU, especially in the first week, I suggest to use 20 kilocalories per kilogram, 20. If the patient is in the ward, if the patient is not critically ill, I suggest to use 30 calories. In my daily practice, I never use formulas like Harris-Benedict or Schofield, either indirect calorimetry or kilogram-based formulas.
Clear. And for the protein, it's, I think, straightforward, 1.3 minimum and the target dose, I think.
Yeah, according to ASPEN 1.2, according to ASPEN 1.3, but generally 1.3 is a good number. You know, in the past we were using 1 gram, but today it's too low. especially for the critically ill patients, for cancer patients, for the critically ill, for surgical patients, at least 1.2. And in my daily practice, if the patient is stable, in many patients with protein loss, I sometimes use 1.5 also.
Okay. What about the energy requirements of the burn patients?
Okay, it's a different topic. It's a different topic. The energy requirements of the burn patients is significantly increased, and we have different formulations. I would like to refer the attendees to these formulations. The energy requirements may change according to the degree of burn and also according to the area of the burn, according to the burn area. And an important issue in these patients is hypermetabolism. Their both energy requirements are increased up to 40 kilocalories per kilogram, and also their protein requirements are increased up to 2 grams per kilogram. You know, they are losing proteins not only because of protein breakdown, but also because of skin loss, because of secretions, body secretions. So these are an important group, and they should be monitored very closely.
Okay, clear. Thank you. And there are a couple of questions about the overfeeding.
Yeah.
Can you discuss the risks of overfeeding a little bit more? Why is it dangerous?
Yeah. During my residency, we were calling parental nutrition as hyperalimentation. Why? Because at those days we were giving as much as we can. We thought that if we feed our patients like mothers feeding their babies, it will be better. But because of seeing the potential complications of overfeeding, we realized that overfeeding is dangerous. There are many concerns with overfeeding. First of all, if you overfeed your patients, the risk of hyperglycemia is increased. You very well know, Anil, hyperglycemia is associated with increased mortality rates. So hyperglycemia should be prevented. How? Avoid overfeeding and also regulate blood sugar. If needed, you can use insulin infusion. Another concern is acidosis. If you overfeed your patient, this will result in more carbon dioxide production. And this carbon dioxide production will further increase acidosis, especially critically ill patients. Third concern is increased blood urinary nitrogen. If the patient has renal failure, their blood urinary nitrogen level will also increase, which may render the patient to a complicated outcome. And finally, high energy is expensive. I mean, you don't need to do that. And in the long run, not in the first few days, overfeeding may result in liver toxicity, hepatosteatosis, or steatohepatitis. This liver toxicity is usually seen after 3 weeks. It's a late consequence of overfeeding. So basically, acidosis, hyperglycemia, increased nitrogen excretion, liver toxicity, and increased cost.
So I would like to connect this with another question. The question is, why does TPN damage the liver? Does TPN damage the liver? Let me ask this way.
No, actually TPN or PN, it's better to say PN. PN does not damage the liver. The damage is caused by hyperglycemia. In parenteral solutions, we have proteins, we have lipids, and we have sugars. Which one is more toxic to liver? Lipids, proteins, or sugar? Sugar is most toxic component of parenteral nutrition. If the patient is not hyperglycemic, if you don't overfeed the patient, the risk of hyperglycemia is decreased and steatohepatitis is decreased. So in these days, in short term, we rarely see liver toxicity. And there is an error or misunderstanding, Anil. In some cases, if there's an elevation of liver function tests, some physicians may link this to parenteral nutrition. But other causes like multi-system organ failure or sepsis or some biliary disease may contribute to the development of liver injury. So before saying PN-induced toxicity, one should rule out other reasons of steatohepatitis or liver steatosis.
Okay, then let's continue with another liver question. When you see that rise in the liver enzymes, what do you do if the patient is receiving parenteral nutrition?
This is an excellent question. Basically, we have two strategies. First, we should rule out other causes of liver enzyme elevations. And if we couldn't find any other reason, then my first measure is to decrease total calories. As an example, if the patient is on 2,000 kilocalories, I decrease it to 1,500. And if the patient is getting better, no problem. But if there is a further elevation in liver function tests, the next step is to decrease sugars and increase lipids. So, for example, you can use 50-50 lipids and glucose ratio instead of 60 glucose, 50 lipids. Decrease sugar and increase lipids in the energy content. If still liver functions are elevating, then you may need to further decrease the total energy amount. Mm-hmm. So step-up approach.
Okay. And about the lipids, okay. There is a question about the lipid initiation timing. When can we safely initiate lipid in critically ill septic patients? Does that depend on the type of the lipid we use, the initiation time of the lipids?
Basically, the answer is day zero. When you place your patient on parenteral nutrition, you can start infusing lipids. You don't need to wait. Lipids are an essential part of parenteral nutrition regimen. You don't need to wait. Regardless of the type of lipid, either olive oil or soybean oil or fish oil, you can start on day zero. You don't need to wait.
Okay. And there is a couple of questions about glutamine. What is the optimal dose for glutamine? And in critically ill patient, what should be the percentage of glutamine to the total daily protein?
Actually, there is no clear data on that. Maybe my colleague who's asking this question is critical about the use of glutamine. Regarding ESPEN guidelines, for example, glutamine supplementation may be considered in patients who are not adequately fed with enteral nutrition alone. So basically, we don't need to use glutamine in all the cases. But if you use, it depends on the patient's underlying disease. Basically, the guidelines recommend glutamine in trauma patients and in burn patients. In the rest of the patients, if they have some enteral nutrition, they don't require parenteral nutrition. They don't require parenteral glutamine. If they are only on parenteral nutrition, you may use, I don't say you should use, you may use parenteral glutamine. And the dose is usually 0.3 gram per kilogram per day, and it may be doubled. I know that there are different approaches, but I have to say that ESPEN recommendation in 2021 guideline is a grade 0 regarding glutamine, which means we don't have much data. We don't have much data. This is just an expert opinion. So basically, I can't give clear recommendation about glutamine use. In my daily practice, I don't use glutamine very often. I use in selected patients, in burn patients and in trauma patients.
Professor Osman, we have quite a lot of questions actually. Do you have time, a few minutes more for answering them?
No, I am fine. We can discuss for 5 more minutes. I will be happy to answer the questions. Okay. I will be happy.
Yeah, there are quite a lot of questions. You mentioned about starting lipid infusion or adding the lipid to parenteral nutrition starting from day 0. What if the patient has high triglycerides and cholesterol?
Oh, okay. Also, this is a very nice question. Anil, to tell you the truth, in my surgery life, I have seen only 2 or 3 patients in which I have to cut lipids. A mild elevation is not a contraindication for lipids. Usually the recommendation is 3-fold increase in lipid levels. If the laboratory upper limit is 400, you can use up to 1200 as an example. So up to 3-fold increase you can use. But if you want to be on the safe side, you can decrease the lipids ratio if the patient has elevated lipid and triglyceride levels. But basically, in the majority of patients, you don't need to make any restrictions up to 3-fold increase in triglyceride levels.
And the information that you have shared from your perspective, that you have seen only 2 or 3 patients in all your practice, is quite important.
But this may be a problem in infants or in some congenital diseases. This may be a problem of the pediatricians. As an adult physician, this is not a major problem in my daily life. But in pediatric patients, this may be a real problem in newborn errors.
Yeah, I see. And there is a question about using heparin to help improving the lipid metabolism. Do you use such kind of a technique? No. The question starts like this. Some patients on PN and with high triglycerides, it is difficult to reach the goal of calories, especially if the patient is diabetic. What do you think of using heparin to help improving the lipid metabolism?
To tell you the truth, I am not aware of heparin to improve lipid metabolism. I am not aware of this approach, and I haven't read about this, but I will investigate, promise. I don't know the answer. But sometimes we use, we use heparin lux for central lines It's not a general practice, but I don't have any experience regarding lipid metabolism. I don't know.
Okay, I will look at it as well. It's an interesting question for me as well. Okay, coming to the lipids again, how do you select the lipid emulsion to be given to a patient? What is your strategy?
This is a critical question. In my institution and in my center, we use basically olive oil. Why olive oil? Because of its immune neutrality. Principally, I'm a physician who doesn't want to touch inflammation and immunity response of my patients. Because of immune neutrality, I use olive oil in all of my patients. But I don't want to say that the other lipid emulsions shouldn't be used. According to ASPEN guidelines, soybean oil, fish oil, and olive oil is equally effective and safe in critical patients. And also according to ASPEN, these lipid solutions can be used safely. But, besides medical reasons or medical answers, also there is an economical answer. The cheapest one usually is soybean oil. Soybean oil is cheaper. But the price difference between olive oil and soybean oil is not that much. So from economical standpoint and regarding immune neutrality, I use olive oil.
Okay. Actually, we have passed our time for 5 minutes now. There are still some questions, but actually I want to end this webinar with 2 or 3 takeaway messages from your side. My one message would not be sufficient, but what would you expect our audiences to remember from this webinar? 2 or 3 points.
Basically, I have to say that parenteral nutrition is safe. So don't be scared. You can use parenteral nutrition safely. It's effective, efficient, and safe. That's my first take-home message. And my second take-home message is immune neutrality is an advantage of olive oil, and I suggest to use olive oil in their patients. And my third take-home message is please deliver at least 1.3 gram of proteins per kilogram per day to your patients. Protein is critical and essential, especially for the critically ill. And my final message is, please consider supplemental parenteral nutrition if enteral nutrition alone is not good enough to meet the energy and protein goals.
Thank you. Thank you very much, Professor Osman Abbasoğlu. It was really a pleasure listening to you and having this question and answer session and answering the questions from our audiences. We are sorry that we still have a few questions left, but we don't have much time. Maybe we can answer those questions by email, Professor Abbasoğlu. Would that be okay for you? I can share.
I will be happy to. I will be happy to, with pleasure.
Great, great. And hope we can add more pictures for your next presentation from Middle East. I mean, hope we can see each. Hope we can welcome you in Middle East and add more photos to your album so that you can use in the upcoming presentations. Thank you very much, Professor Osman. Any last words that you would like to say to our audiences?
Thank you and stay healthy.
Thank you. Thank you very much, everyone, for your time, and looking forward to being with you and seeing you face to face in the near future. Have a nice evening. Bye-bye.